Dear faculty members, dear colleagues, I really want to express a warm welcome to all of you. We are particularly happy to have participants from different countries, neighbors, but some of them are far away, and that we'll spend 2 days actually on this course on atypical Parkinsonism in the organization of, as you all know, International Parkinson and Movement Disorder Society, European section. As an old man, I know from my experience that the only critical moment in every meeting, of course, is the moment of beginning, is the moment when this course starts. And this is the moment. After that, everything will go this or that way. We are done discussing about, can I get the slides, please? Atypical Parkinsonism, and I was actually planned to give a lecture due to some health problems. I will give something like a soft introduction to the whole story. Mogu da dobijem slajd, molim te, prezentacije. I možda vidiš. Okay. We are discussing about atypical, but the contrapunct of atypical is something that is typical. And of course, this is a very interesting interplay because when we analyze the knowledge we gain in the previous few decades, the boundaries between typical and atypical are fading, and to some extent to the overlapping, we have to be very cautious when we discuss about particular aspects of typical versus atypical. Even after all these years, we have a little bit of problems in diagnosing Parkinson's disease, despite the apocryphal stories that we can do it through the window of our room or something like that. In this study that comprised 20 studies, this analysis of 20 studies, 11 of which were pathologically proven cases, particularly for these 11 studies, pooled diagnostic accuracy was about 80%. We may gain something with all these scales, which you are all aware of, but the conclusion is quite simple. The accuracy did not significantly improve in the last 25 years, particularly in the early stages of the disease, when we have a problem in differentiating Parkinson's disease from atypical Parkinsonism. Of course, we have to be very cautious about the conditions that may mimic Parkinsonism, like we're always fascinating with slow execution of movements, which may be due to decreased motor control, pyramidal lesions or ataxia, apathy, other cognitive problems, depression, metabolic cases like hypothyroidism, and also psychogenic slowness. Also, there may be mimics of lack of spontaneous movements, like again in psychogenic, but also in situations like dystonia on the frozen shoulder when we have diminished arm swing, or lack of expression, actually, mask face in patients with depression. Cog-wheel phenomenon we may find also in some cases of essential tremor, drug-induced tremor, and something that may be quite alike classical resting tremor is, of course, dystonic tremor. We all know that in the field of Parkinsonian syndromes, idiopathic Parkinson's disease is by far the most frequent, 85% of all cases. Then we have secondary Parkinsonism due to different reasons, particularly vascular, and you will find in the literature something that is actually never been scientifically proven, that about 5% of these cases are vascular Parkinsonism. Is it true or not? I'm not quite sure. Also, we have hereditary Parkinsonism, but what is the topic of our lecture today is atypical Parkinsonism with progressive supranuclear palsy, which is about 3%, or multiple system atrophy, 2%, corticobasal degeneration, dementia with Lewy bodies, and some may include actually what I already mentioned, vascular Parkinsonism. The important point is that all these entities in a typical Parkinsonism may be cases of different types of proteinopathies, like synucleinopathies, Parkinson's disease, multiple system atrophy, DLB, dementia Lewy bodies, and tauopathies, just to make this clear distinction, although it's not quite true, it's a corticobasal degeneration and progressive supranuclear palsy. We started from something that might be atypical from Parkinson's disease, and let's start with the motor features. First, we have rapid progression, and you can see here on this cartoon that actually all atypical Parkinsonism have a similar pattern of progression to the Hen and Yahr stage 5, which is quite different from the progression of idiopathic Parkinson's disease. Early instability, falls, and freezing. Here you have latency to falls, for instance, which is about 106-8 months in Parkinson's disease. The shortest is in PSP, and MSAP, dementia Lewy bodies, and vascular Parkinsonism is between 40 and 50 months. Absent or poor response to levodopa, myoclonic or jerky tremor, pyramidal cerebral signs, early dysarthria. Look here, early dysarthria, early dystonia contractures. We'll be back on this point. Predominantly axial rigidity, absence or paucity of tremor. Even when we look at the basic aspects of motor features like rigidity, we may say that unilateral onset and persistent asymmetry is a hallmark of Parkinson's disease, but this may be true also for most MSRP cases or typical corticobasal syndrome. In Richardson form of PSP, we have predominant axial rigidity, while the limbs are more or less unaffected, at least initially. Classical resting tremor, which may be stopped by voluntary movement, etc., is mainly a case in Parkinson's disease and PSPP, variant of PSP. But even in the classical Richardson form, there are some studies showing that about 10% or something less than 10% of these patients may have classical resting tremor. However, it almost rules out MSA or corticobasal syndrome. And why unilateral onset and persistent asymmetry favors Parkinson's disease? Such symmetric onset but persistent unilaterality is not compatible with PD diagnosis. Myoclonus is frequent, particular reflex myoclonus in MSA, corticobasal syndrome, but not in here Parkinson's disease, DLB, synucleinopathies, and PSP tauopathy. Maybe even the whole grail of Parkinson's disease, bradykinesia, is not the same, let's say, at least in synucleinopathies and tauopathies. And here we performed something like a taping test, nothing particular. You can see in healthy controls that both the amplitude and the speed of movements are preserved in the sequence that we are testing. In Parkinson's disease, we have decrement, actually. You can see here, this is a sequence effect, that with every other movement is a smaller and smaller amplitude, and also decrease in the speed of movement. However, in PSP, we have so-called hypokinesia without decrement. It's a small amplitude, which may be even sometimes very fast. And this average finger separation in PSP may be less than 50%, what we can see actually initially in patients with PD and healthy controls. So this is, we can discuss, of course, about the pathophysiology, but even this type of features in PSP and Parkinson's disease may not be the same. Here is our study that show actually no change in patients with PSP and decrement in patients with PD. Similar behavior have patients with MSAP. They have sequence effects with decrement. What about dystonia? Both in MSA and in PSP, it's non-fluctuating, contrary to Parkinson's disease, when it's more often in off periods like classical foot dystonia, etc. In MSA, it may develop rapidly into fixed dystonic contractions of hand and feet, When it affects laryngeal muscles, it may be an inspiratory. We'll see that later in the videos, and inspiratory size. Anticolis is a red flag of this particular entity. In PSP, it may affect nuchal muscles, leading to retroflexion, this type of position with dignity, and the frontalis muscles with typical astonished fasces. Corticobasal syndrome is interesting because dystonia of an affected limb may be a symptom of diagnostic relevance. Even at the beginning, we said that abnormal postures like bent posture, camptocormia, Pisa syndrome, etc., may be quite frequent, but their early appearance suggests multiple system atrophy. In PSP, of course, we have backward falls, rocket sign, etc. What is a typical in the sense of autonomic dysfunction? Of course, it's as a red flags, impotence, early orthostatic hypotension, early and or severe urinary disturbances, which are all very well known. But again, take message early. What does it mean? We'll see later. Autonomic dysfunction is, of course, a core MSA feature. We all know that. But it's also quite often in other synucleinopathies where it may make differential diagnostic problems, for instance, between MSA and dementia fluid bodies, where it may also start even in the early stages. There is a kind of suspicion that in tauopathies, if you have such a problem, it may be due to the comorbidity. A few interesting clinical points I want to stress from the paper of Günther Hoglinger, who is a presenter in this meeting. This is urge incontinence quite often in all Parkinson syndromes, especially in PD. But if you have urinary retention without urgency and without identifiable cause, it's suggestive of MAC versus all other Parkinson syndromes. Also, there is some specificities. For instance, erectile dysfunction without effect of sildenafil, particularly affecting early morning spontaneous erection, is also highly suggestive of MSA. When we have oculomotor features, which will be a particular part of this symposia, of course, we have to take care of marked slowing of saccade, supranuclear gaze palsy, nystagmus, etc. And I am not going to discuss in details because you will have later on this presentation, but there is a huge overlap of such problems in Parkinsonian syndromes, but subtle differences sometimes or often we are not able to catch with a bedside examination or during routine examination, so some technical approaches might be also necessary. Here is actually bedside screening in PSP, but you will hear about that. What about cognitive and behavioral features? And of course, we have early and severe dementia, visual hallucination, early visual hallucination, or non-drug associated visual hallucination, ideomotor apraxia, sensory or visual neglect. Frontal signs are frequent in PSP and corticobasal degeneration, so we have to test Appel's sign, grasping reflex, palmomental reflex, etc. While parietal signs are mainly or almost only in corticobasal syndrome, but not in other Parkinsonian syndromes. Orobuccal or limb apraxia and cortical sensory loss, all of them classified as cortical, are rather suggestive of corticobasal syndromes. Apraxia of speech is also considered characteristic for tauopathies. Of course, we have some other symptoms like sensory dysfunction, where hyposmia may be very suggestive for Parkinson's disease, but normosmia for a typical Parkinson syndrome, although it is not making distinction between specific entities of atypical Parkinsonism. Sleep disorders, idiopathic REM sleep behavior disorders may be accepted as an indicator of synucleinopathies, and it's hardly observed in tauopathies. So all the times we were discussing about early, prominent, what does it mean early? We can find some clues actually in postuma criteria like rapid progression of gait impairment requiring wheelchair or patient to be wheelchair bound. It's within 5 years of onset, absence of progression of motor symptoms assigned over 5 years or more, early bulbar dysfunction less than 5 years from onset. You will see that there is a dissociation from some criteria that we have facing through all these years. Severe autonomic failure, less than 5 years of onset, recurrent falls from imbalance between 3 years of onset, antecholis or limb contractures within 10 years of onset, etc. Even an early study showing down here in this cartoon is suggesting when all these problems appear in different types of, here is a mistake, it's corticobasal degeneration, no GBD. And I'm not going to details, but one of the conclusions of this paper is that the typical Parkinsonism unmasks within the first 4 years. Particularly in MSA, there is a lot of things that we have to bear in mind, like we already said that idiopathic REM sleep behavior is common in MSA, and together with the autonomic dysfunction may represent actually a premotor stage in many MSA patients. However, it's important to take as a message that early postural instability may be also the feature of MSA, not only PSP. Orofacial dystonia, sometimes asymmetrical, which you also will have chance to see, is actually spontaneous or levodopa-induced, rare in PSP, corticobasal degeneration, but in MSA it's a kind of red flag. I'm not going to discuss about all of this, but early dementia, considered a non-supporting feature previously, hallucinations, early slowness of saccades, clinically significant neuropathy, age at onset above the age of 75 years, and extensive white matter changes do not support the diagnosis of MSA. So, cognitive impairment in multiple system atrophy sometimes may be a frontal executive type, but prominent early dementia should lead us to think about different diagnoses. So we are facing here with the different phenotypes, and one suggestion is that they are likely the consequence of distribution of the underlying pathology in each of these disorders, and thus reflect more likely a spectrum rather than the well-defined phenotypes which we are trying to do. In the corticobasal degeneration and corticobasal syndrome as two opposite things, I have to say that something more than a third of corticobasal syndrome patients have underlying pathology that is other than the pathology of corticobasal degeneration. Here you have all these situations. Also, with the patients with corticobasal degeneration, proved pathology, phenotypes other than CBS may appear. And here is a recent, actually, analysis of corticobasal syndrome phenotypes, including frontal behavior, dementia variant, posterior cortical atrophy syndrome, progressive non-fluent agrammatic aphasia, progressive PSP syndrome, etc., etc. However, in some of these patients, we may have situation when the patient has something on the borderline between PSP and CBD, having actually for both diagnosis criteria, and we called it PSP-CBS hybrid. However, some authors think that it's a cortical PSP variant, that it may be actually some kind of shift of tau burden towards the cortical regions away from the basal ganglia. We also have a vascular Parkinsonism. Vascular Parkinsonism, which I say is a little bit a strange construct, because we are not always sure, is it a single etiology or maybe it just help existing Parkinsonian pathology, etc., etc., with the problems like gait and balance disturbances, depression, cognitive decline, urinary incontinence, etc. So why is it important? Because both etiologies are common in all the population. They have an overlap syndrome. They present concomitantly. Of course, as a proof, we have coexistent cerebrovascular lesion in about 20% of PD cases, subcortical white matter changes or lacunes of the basal ganglia, that lacunaire, in about 15% of patients. So there is a synergistic effect between both pathologies. How can we see that through suboptimal response to dopaminergic treatment, PhD, phenotype, dementia, et cetera, et cetera. So it's important to have this in mind, although vascular lesion, it has been described in literature, may pretty precisely mimic PSP, but also in some of the reports, corticobasal syndrome. So at the very beginning, I just want to say we were discussing what is atypical from Parkinson's disease, and now I want to take a small side from the other side of the mirror. What is actually typical in what we are calling typical? Why? First of all, because we are all aware that Parkinson's disease, which we are taking as a baseline, is actually very heterogeneous. We all know these subforms based on tremor dominant, PhD, et cetera, et cetera. But recent studies have shown actually distinction that is pretty repeated in different reports on so-called diffuse malignant form, mild motor predominant form, and also intermediate. These groups actually very nicely sequestrate on different milestones like death, first milestone, dementia, falls, home care, wheelchair bound, etc. And you can see here that diffuse malignant develop all these milestones quite earlier in comparison to intermediate and mild motor predominant form. This is also seen here, black line is for the diffuse malignant form. Obviously, everything of these milestones are coming much faster in this subgroup of patients. But the pattern of time is almost equal like we have actually in a typical Parkinson's disease. So this question of progression have to be put in the context of such heterogeneity of disease progression in even notorious Parkinson's disease. On the other side, we were all happy with the initial classical diagnosis of Richardson syndrome, still Richardson-Olszewski syndrome previously, of PSP, knowing by heart all these criteria that we can use for diagnosis. And in 2005, as I remember, Williams and one group described a variant of PSP Parkinsonism, which was very interesting because they found that, let's say approximately, in the first 2 years, it's almost impossible to differentiate this disorder clinically from idiopathic Parkinson's disease. But later on, we have a number of other variants of PSP. I'm not going, of course, to speak in details. You will see it later. With some claims that after 4 to 6 years, there somehow became clear what are in question. But in the first early years, we are really in the situation that we cannot clinically easily differentiate all these problems. The even greater shock came in 2014 when Respondek and colleagues published a study of 100 definite cases, pathologically proven definite cases of PSP. And what was interesting, that only about a quarter of them presented as classical PSP Richardson syndrome, but over 50% show different overlapping features of previously described phenotypes, or not fitting at all to any of these, or partially to any of these variants. So the conclusion was that phenotypic spectrum is much broader than we believe and more variable than described, so that too strict clinical criteria may not reflect this variability. And I think that in this sense, a new criteria that have been published a few years ago are really coming to the conclusion or follow this trace that we are facing some unpleasant variability for us who are simple clinicians. Finally, some of the genetic forms we are all aware of, Parkinson mutation, PSP-like. Our first family were two sisters and one brother who have a clinical phenotype of PSP. But the disease started in the age of from 16 to 18 years, and they were all carriers of Parkinson mutations. Here I just want to show one genetic risk factor, but mainly the most robust genetic influence in Parkinson's disease. It's a GBA, actually, mutation, which were present in about 6.5% of our PD patients and in only 1.4 controls. So the OD ratio was about 5. It was clear from the very beginning that they are not quite the same like the patients we are facing every day. And it was early onset Parkinsonism, faster progression, and a large number of non-motor symptoms, but particularly progression of dementia. With colleagues in Milan, and we have as a guest Federica Agosta here, proved that there is a change actually faster in those who are carriers than in those who are not carriers. But clinically, you can see that there is a faster progression of the disease according to Henin-Yar stage. You see this red against those who are not carriers, UPDRS scale, but also a revised Addenbrooke scale, where you can see a cognitive decline, which may make also differential diagnosis complicated. We also have to bear these genetic influences in mind. So the problem is obviously not so simple like it used to be in the Green Valley of my youth, but real experts of this problem will try to explain to you all the questions. Thank you very much. Now I want to invite Iva Stankovic to give further details.
After Professor Kostic provided such a nice introduction about atypical Parkinsonism, there is not much left for me to say, and I will just again mention very briefly that for a clinician dealing with patients with Parkinsonism, it is mandatory to recognize symptoms and signs of atypical Parkinsonism. And this is a small summary of what has been said by Professor Kostic already. So a clinician must know what symptoms to carefully pursue in a single patient, because there is, as you already heard, a number of motor, autonomic, oculomotor, cognitive, and behavioral symptoms that are atypical for Parkinson's disease, but that are core or supportive clinical features for atypical Parkinsonism. Also, the natural history, as you already heard, is very different from that of Parkinson's disease, with more rapid disease course and shorter latency to disease milestones. Next is for all of you who are dealing with atypical Parkinsonism and show some interest in this disorder, is to understand the utility of different diagnostic tests, namely neuroimaging, autonomic function tests, sleep tests, cognitive and behavioral assessment, and there are many more. Recent international efforts led to development, as you probably know, of the new clinical diagnostic criteria, neuroimaging, and fluid biomarkers with excellent diagnostic accuracy and rating scales for disease progression, and this will all be discussed during this course. The clinician should know which laboratory test is useful in differential clinical contexts, how to interpret the test results, and when in the disease course the best performance of the test could be expected. And the third step in dealing with the patients with atypical Parkinsonism is to design a multidisciplinary approach of care, which is crucial to design the patient-centered treatment strategy. The multidisciplinary approach, including symptomatic management and allied health intervention, is current standard of care while potentially disease-modifying agents are being tested currently in different clinical trials attempting to slow disease progression. And we will have the management session as a last session tomorrow afternoon. Now, the most important slide is a thank you slide. I would like to provide a huge thank you to those who helped us organize this meeting. I would like to especially acknowledge Heather Vitale from MDS. Heather, thank you so much. Heather is really the core organizational and executive person within the European section of Movement Disorder Society. I would like to thank to the representatives of Society of Serbian Neurologists, and of course, a huge thank you goes to the local organizing committee from our neurology clinic in the Clinical Center of Serbia. And please, one applause also for these people. Because without them, this court could not have been organized. With this, I would like to warmly welcome you again to the course, and I hand over to Professor Kostic, who is chairing the first session. Thank you so much. Okay, so dear colleagues, as Gunther mentioned, distinguishing early atypical Parkinsonism from early Parkinson's disease is the most critical issue probably in the diagnosis of these disorders, because an early and correct diagnosis is prerequisite for patients' counseling, for prognostic estimations, multidisciplinary care planning, and inclusion in clinical trials with disease-modifying drugs. So I have nothing to disclose. A key question, a philosophical one, would be what is early in neurodegenerative disorders, and this is actually very difficult to answer to this question, at least based on the knowledge we currently have. It could be the pre-diagnostic stage when biomarkers are positive, but there are no clinical symptoms. It could be prodromal stage of synucleinopathies, for example, occurring 20 years before the motor onset, with hyposmia being the earliest sign, followed by REM sleep, atonia loss, erectile dysfunction, constipation, color vision dysfunction, and urinary dysfunction. These symptoms tend to progress slowly over time, while closer to the motor onset, in the preclinical phase, there are subtle motor signs which tend to emerge with a steeper progression, and the same is true for cognitive impairment in Lewy body disease. By early, one could also mean early phase of motor symptoms, which is usually defined as the first 3 or maybe 4, but let's say 3 years from the motor onset. So in the present talk, we will discuss which clinical features and which laboratory tools can help us diagnose atypical Parkinsonian disorders in the prodromal phase and in the early phase within 3 years from symptom onset. Prodromal phase of synucleinopathies is now well defined with diagnostic criteria for prodromal Parkinson's disease, prodromal DLB, and possible prodromal multiple system atrophy. While the early stages of Parkinson's disease, which is first 5 years for this disease, and early stages of PSP are defined with the criteria for clinically established Parkinson's disease and a category suggestive of PSP within the MDS-PSP criteria. Among the early stage criteria, prodromal PD criteria are validated so far, and these are reported to have low sensitivity and fairly good specificity. And the criteria for early Parkinson's disease also have sensitivity of 70% and excellent specificity, while the prodromal criteria for other disorders have not been validated yet. Neuropathological studies have documented that almost all patients with video polysomnography proven REM sleep behavior disorder and the neurodegenerative syndrome, meaning Parkinsonism or cognitive impairment, have an underlying synucleinopathy. In 50% of patients with RBD, this disorder preceded the onset of other features for as many as 10 years. Phenoconversion rate of idiopathic REM sleep behavior disorder to synucleinopathy is estimated to be 6.25% per year in a recent large multicenter study, and the mean time to phenoconversion was 8 years. 75% of patients from this study phenoconverted to synucleinopathy within 12 years of follow-up. Another confirmation that RBD is synucleinopathy comes from the study reporting sensitivity and specificity of more than 90% for misfolded alpha-synuclein detection in the cerebrospinal fluid in patients with RBD using RT-QuIC method. During follow-up, 60% of these patients were diagnosed with Parkinson's disease or dementia with Lewy bodies, a mean 3 years after the lumbar puncture, of whom 97% were alpha-synuclein positive at baseline, suggesting that synuclein positivity is associated with increased risk of subsequent diagnosis of Parkinson's disease or dementia with Lewy bodies. Different clinical features, such as subtle motor impairment, impaired olfaction, autonomic features, REM atonia loss, and color visual abnormalities predicted the phenoconversion of RBD to synucleinopathy, but only the cognitive impairment is being the single predictor of which differed in patients that phenoconverted to dementia compared to patients who phenoconverted to Parkinsonism. A subgroup analysis showed that patients phenoconverting to MSA were younger, they had preserved cognition and color vision, they had less impaired infection and more urinary symptoms. This is a patient who had RBD from age of 60 years. On this video you can see severe orthostatic hypotension in the first minute of standing. This occurred after 6 years from the onset of RBD. Then the patient also developed Parkinsonian signs, and also he had mild cognitive impairment on MoCA scale, predominantly in the frontal executive domain. And his MRI was normal. That SPECT, of course, showed bilateral dopaminergic denervation, which was slightly asymmetric, and he had incomplete cardiac sympathetic denervation. This patient is an excellent example how one patient actually could fulfill two criteria for two disorders. So here, if we, on the left side, are criteria for prodromal Lewy body dementia, and here we see that essential is mild cognitive impairment, then core clinical features are fluctuating cognition, recurrent visual hallucinations, RBD, which was present in these patients, and Parkinsonism, which was also present, and then there need to be also biomarkers, which in this case is a reduced DAT uptake on SPECT, and reduce MABG SPECT on heart scintigraphy. So actually the diagnosis in this patient could be probable MCI Lewy bodies, which is a prodromal phase of Lewy body dementia, but also this patient fulfills the criteria for clinically probable PD, because here we have the cardiac sympathetic denervation, which is a supportive feature of Parkinson's disease, counterbalanced with severe autonomic failure occurring within 5 years from symptom onset. This patient at the end really had dementia with Lewy bodies, but this is just an example that criteria are really sometimes not ideal, although they are quite good and very useful in the clinical practice. So the second scenario in the prodromal phase would be the presence of autonomic failure. And if we have an autonomic failure as an isolated feature, then if there is also a Parkinsonism, the differential is, of course, within PD and MSA. If there is also cognitive impairment, we should think of dementia with Lewy bodies and Parkinson's disease dementia. And also, if there are some cerebellar features, then we should think of MSA. If there are no other neurological abnormalities for more than 5 years, the diagnosis is pure autonomic failure, which is another synucleinopathy. And this lady, let us hear the story. Oh, we cannot We have no sound, but yeah, I can.
Dizziness and lightheadedness, I would say probably was
Can you make it
almost
a little bit louder,
around
please?
the same time as the sleep
thank you.
disturbance. So I just figured, well, menopause, again, you know, that's catch-all for everything with a woman at that age. I started noticing, you know, little bits of escape of urine and frequency, and started with a urologist, and he started treating me with the medications, and we tried quite a few of them, and nothing really worked significantly.
Okay, so here we see the history of isolated urogenital failure, and also she had orthostatic hypotension on head-up tilt. This urinary first form of MSA actually occurs in 80% of patients, and here usually we have urogenital symptoms. In the natural history of MSA, usually urogenital failure comes first, and then it is followed by orthostatic hypotension in 60% of patients. Mean latency to onset of motor symptoms in one study was 3 years. And on this graph, it is shown that already in the first year in patients with MSA, the mean post-void residual volume was 70 milliliters, and already in the second year from symptom onset, it was more than 100 milliliters, and these patients, for example, could fulfill the criteria for clinically established MSA. And now, if we have a look at additional investigation in these patients, so she had really increased post-void residual of 140 milliliters, she had RBD, and she had normal smell on the olfaction test. And here is the patient showing some mild Parkinsonian motor signs, which could not satisfy the diagnostic criteria for Parkinsonism and do not require dopaminergic drugs. And this patient really fulfills the criteria of possible prodromal MSA. And as we already mentioned this in the previous talk, I will just move forward for the sake of time. Similarly to isolated REM sleep behavior disorders, also patients with pure autonomic failure phenoconvert over time to synucleinopathy with central involvement. When cerebrospinal fluid of 31 patients with pure autonomic failure was tested for alpha-synuclein oligomers, it appeared that 5 samples strongly separated from other samples with markedly lower maximum theoflavin fluorescence with earlier start of aggregation and formation of the reaction plateau that fell perfectly into the previously established pattern specific for MSA, and that all 5 of those really later developed MSA. Theoflavin T fluorescence of all other reactive samples was markedly higher and fell into the range that was previously established for Parkinson's disease and dementia with Lewy bodies. 2 of those patients indeed developed Parkinson's disease, and 2 developed dementia with Lewy bodies during the follow-up, and none of them developed MSA, suggesting that this method, which I mentioned several times today, is actually really quite accurate also in the prodromal phase of synucleinopathies. And several studies addressed the predictors of phenoconversion. It appeared that these predictors quite differ for MSA and Lewy body disease. So in MSA, if a patient has pure autonomic failure and then some subtle motor signs, earlier onset in their 50s, severe bladder symptoms, supine heart rate greater than 70 beats per minute, and with greater increase of heart rate, so more than 10 beats per minute after 3 minutes in the upright position, supine norepinephrine levels greater than 100 picograms per milliliter, normal smell, preganglionic pattern of anhydrosis, and this specific pattern of aggregation of oligomers, then this patient will likely phenoconvert to MSA. On the other hand, if a patient has a later onset in 60s or 70s, again, some subtle motor signs, constipation, here anosmia, and a supine heart rate which is lower than 70 beats per minute, and with diminished increase of heart rate upon standing, which is lower than 10 beats per minute, then this patient will likely progress to Lewy body disease. So in the case of our patient, she really developed, which you can see also on this video, a full-blown MSA phenotype, also supported by imaging markers of putamen atrophy and hyperintensity, cerebellar and pontine atrophy, and metacerebellar peduncle atrophy and hyperintensity. The third scenario is early disease. How can we differentiate patients in early disease, so 3 years after the motor onset? According to the MDS-PD criteria, the diagnosis of clinically established PD requires an absolute exclusion of, the absence of absolute exclusion criteria, the presence of at least 2 supportive criteria, and no red flags, which is the case on the first graph. And then a diagnosis of clinically probable PD requires the absence of absolute exclusion criteria again, but the presence of up to 2 red flags that can be canceled out by the presence of 2 supportive criteria, which is the case on, so 2 red flags and 2 supportive criteria on the third graph, and in the middle one there is 1 supportive feature and 1 red flag, so both mean the diagnosis of clinically probable PD. And in the second line, there are patients who would be diagnosed with atypical Parkinsonism because of the predominance of atypical features, and predominance of red flags. However, the problem here is that really the classical red flags that were very nicely presented by Dr. Petrovic before are really a feature of an advanced disease. And in these clinical pathological studies, it has been shown that they have excellent specificity, but their sensitivity is quite low in the first 3 years, so they cannot really distinguish patients with MSA in this case from patients with Parkinson's disease. Another problem, among many other problems, is that levodopa response may be good or moderate in early disease stages, as shown in these 2 large natural history studies from Europe and from the US. They actually report that for the first 3 years, patients with MSA usually have beneficial levodopa response. And actually, levodopa responsive Parkinsonism is a core clinical feature of clinically probable MSA according to the MDS criteria, and level 3 core clinical criterion for the PSP diagnosis according to MDS PSP criteria. So if we have a look at the accuracy values of these criteria in early disease stages, for the MSA, we see that sensitivity is 62%, which is better than for the Gilman criteria, but however, it is far from perfect, and also specificity is really good in early disease stages. Similar is true for the PSP criteria, where both possible and probable PSP within the first 3 years could be diagnosed in 40% of patients, again with very good specificity, and the only difference is for the early category suggestive of PSP, where there is a very high sensitivity of 85% at the expense of sensitivity, which is also something which is very expected. So which clinical features may help us reach the correct diagnosis? Postural instability and early falls. I will just play the video of an early MSA patient. So postural instability and early falls due to balance impairment are, when present, very suggestive of MSA or of PSP or MSA, and the latency to falls is shortest in PSP and longer in MSA, and also longer in corticobasal degeneration and in Lewy body dementia, altogether being much shorter compared to patients with Parkinsonism. Parkinson's disease, and this is just a history.
Dobro. Koliko imate godina? 69. Dobro. Kada su počele vaše tegobe?
Od aprila.
Ove godine?
Ove godine.
Dobro. Šta ste tada primetili? Ovo
I'm not sure
usporenost,
whether you are
jel?
able to see the title, but
Dobro. Nestabilnost prihoda.
Nestabilnost.
Opišite nam tu nestabilnost.
A kad se oblačim unazad, da padne.
Vuče vas unazad.
Kući unazad.
Jeste padali?
Pa jedno, dva puta sam posebno.
A da li ste primetili da teže gutate ili da teže govorite?
Teže. I govor mislim izmenu.
Dobro, a ste li primetili malo da otežano usmjeravate pogled na dole, na primjer, kad čitate novine?
Ne.
Ne. Kada vam je uveden Madopar, da li ste se bolje osjećali?
Bolje.
Značajno bolje?
Pa bolje.
So in this particular case, the gentleman refers to the symptoms of postural instability, but he says no oculomotor impairment, and his disease duration was several months at this point. And now the other feature that could be useful is for the differential diagnosis from Parkinson's disease early on is freezing of gait. In this clinical pathological study, but Gesine responding and Gunther Hohlinger, it has been shown that actually this feature was present only in 2% of PSP patients. I will show you some videos, and this is really the video of a patient with severe freezing, obviously. And the absence of the freezing in other groups in this study actually led to the fact that, but maybe Gunther will correct me, to make diagnosis a separate category of PSP progressive gait freezing. So if we have a case of only an isolated freezing, then the diagnosis is possible. And if there is some oculomotor impairment, as in the gentleman below, then this would satisfy the diagnosis of possible PSP. But when we conducted another literature review for the freezing in patients with MSA, it appeared that the data are quite divergent, and some studies reporting 0% of freezing in MSA in the first 3 years, but also some studies reporting up to 40% of patients with freezing. So this is something just to keep in mind. Gait issues may also be an early feature of atypical Parkinsonism. So the video number one. This video number one is Parkinson's disease, number two is MSA, number three is PSP. So gait issues may be early feature of atypical Parkinsonism, and according to this European multi-center study, the combination of tandem gait test, retropulsion test, and timed up and go test provides an excellent accuracy for the differentiation of atypical Parkinsonism from Parkinson's disease. Among lower urinary tract symptoms, urinary retention is the most specific for MSA already in early disease stages, and if present so early, it could nicely differentiate MSA from Parkinson's disease and PSP. However, overactive bladder symptoms may be present also in patients with PSP early on, and this is slightly different in advanced disease stages where patients with PSP may also present with urinary retention. Early orthostatic hypotension within 3 years from onset usually points toward MSA, and prolonged tilt for delayed orthostatic hypotension may increase sensitivity for MSA diagnosis. In this nice work of Alessandra Fanciulli, they allocated 1 point for the presence of postural instability, orthostatic hypotension, overactive bladder symptoms, and urinary retention in early disease, and if the score is greater than 2, this means high probability of MSAP in the early disease. And if it is lower, so if it is 0 and 1, it means low probability. Cardiac uptake of MIBG depends on the integrity of postganglionic sympathetic neurons, which are primarily affected in Lewy body disease and are mostly preserved in MSA. In this study, the meta-analysis of 13 studies, it has been shown that actually MIBG SPECT is quite useful also in early disease stages of NDR 1 and 2. And what has been also mentioned and discussed today is dementia and visual hallucinations that may really distinguish Lewy body disease from MSA. And in this clinical pathological study with patients clinically diagnosed with MSA with postmortem diagnostic confirmation, it has been reported that the most common misdiagnosis of MSA was Lewy body dementia. Why? Because both disorders feature the same autonomic symptoms, but the distinguishing features are really those cognitive and behavioral issues, and we can just listen to the story of our patient.
Ta neka devojčica koja vam se priviđala, kako je to bilo?
A ona dođe preko dana, bude i nestane. Dođe ima neki cvijet. I ona to dofaća i pere kosu i namješća kosu. Zabalja, igra se. Kaže mi si gladna, ti si moja. Hoćeš
So
da
we
ti
see
dam
that these
da jedem,
hallucinations
hoćeš
are
da
very
budiš kod
vivid,
mene.
colorful,
Ona ništa.
recurrent, and visual.
Ta neka devojčica
Moving on to the MRI, there are simple approaches to determine infratentorial areas and diameters that are useful to separate PSP patients from non-PSP Parkinsonism, also in early disease stages, according to the several studies conducted in early PSP populations, and these include midbrain to pons ratio and MR Parkinsonism index, which also takes into account peduncle diameters. MRPI index is useful to classify majority of patients with unclassifiable early Parkinsonism to PSP in early stages, according to one study. An interesting question is whether MR features may precede clinical features, and this is addressed in a small study in which it has been shown that in 30% of patients with MSA, actually putaminal abnormalities preceded the clinical diagnosis of MSA according to criteria for a median difference is around 15 months. So this is something that needs further research for sure. The accuracy of MSA and PSP versus Parkinson's disease diagnosis based on the automated volume segmentation of midbrain, putamen, and cerebral gray matter was almost 100% correct at the initial visit, so in early disease stages in this study, compared to, again, clinical diagnostic criteria that had accuracy of 63% in this cohort. And in a meta-analysis of PET studies, all with, that included studies with disease duration shorter than 4 years, an excellent sensitivity and specificity for the diagnosis of both MSA and PSP has been reported, and this is my last slide. So using automated image-based classification of FDG PET, exploiting pattern analysis specific metabolic patterns for MSA, which is bilateral reductions in putamen and cerebral activity, and PSP, showing reductions in the upper brainstem, medial frontal cortex, and medial thalamus activity are defined with close to 100% specificity and also high sensitivity. With this, I would like to just emphasize that really an early and correct diagnosis is challenging, but we now have some new methods that can help us in this journey with our patients, and I would like to thank you for your attention.
I would like also to express my gratitude to the organizers of this symposium, Movement Disorder Society, especially my Professor Kostic and dear friend Eva, for giving me opportunity to speak today. But at the same time, they, I think, at least for me, gave me a very demanding topic on cognitive and behavioral assessment in atypical Parkinsonism. My children were actually witnessing my drama when I started preparing this presentation, and my son, who is 12, was like, why should anyone be worried today? Why don't you ask a GPT chat to do that for you? And I really did. And I was pretty much disappointed because I didn't get any full-blown, colorful presentation, and also with notes for each slide. But I have to admit that I got really good hints from GPT chat about today's talk. And GPT chat told me to pay attention on different patterns that could exist across Parkinsonian disorders, to offer you algorithms and bedside diagnostic tools which are not time-consuming, believe me, and to pay attention of time frame of occurrence of such patterns in context of Parkinsonism and other neurological signs, and to discuss diagnostic challenges in dementia Parkinsonism syndromes, which are actually outlines for my talk today. When James Parkinson first described shaking palsy, it was considered as purely motor disease, but he also clearly noted that the senses and intellect are uninjured, the power of his mind unimpaired. But 50 years later, Charcot was first to dispute it also this part of his observation, and he noted that the mind becomes clouded and the memory is lost. And in the next 100 years, we discovered different type of atypical Parkinsonism, and it has been increasingly recognized that cognitive impairment are inherent condition of all Parkinsonism, from mild cognitive impairment, the one we can see in MSA, to florid dementia, as in dementia with Lewy bodies. Why the cognitive and behavioral deficits are actually obligatory in basal ganglia diseases? This is explained by the fact that the pathways connecting basal ganglia and the cortex project not only in the areas that are responsible for control of motor aspects, but also project in prefrontal cortex, which is a very important part of the cognition, and also project to orbitofrontal cortex and anterior cingulum, which is responsible for behavioral changes in such disorders. And it was PSP that served as a model for introducing new type of dementia, so-called subcortical dementia. In the seminal paper by Albert, he described 7 PSP patients who had an impaired ability to manipulate acquired knowledge, forgetfulness without a true memory deficit, slowness of thought processes, and emotional or personality changes. Almost nothing to add to this description. In contrast to cortical dementia of Alzheimer's disease, where true memory disturbances exist, together with aphasia, apraxia, or agnosia, or other cortical signs. We can actually speak about 3 main patterns that stand out in Parkinsonian disorder. Frontal lobe degeneration-like pattern, PSP and CBS belongs in this square. Pure subcortical pattern, MSA as a representative, and Lewy body disease pattern with PDD and DLB in this group, which are actually showing the signs of both subcortical and cortical dementia. And if we want to distinguish these 3 subtypes of behavioral and cognitive patterns, we need to look into these categories. We need to check for learning and memory, executive function, for higher cognitive functions such as speech, praxis, visuospatial perception, and to notice all behavioral changes. What you will most often hear from the caregivers of patients with Parkinsonism is that they are good in memory, but they are very slow in thinking, and that they need some time to answer on your questions, and sometimes they need some hints and cueing. And the best way to check for this is actually a test, such as Ray verbal learning test, that could distinguish between the categories of encoding and storage, delayed free recall, and recognition. What does it mean? You give the patient 15 words and 5 attempts to learn them. Then after 20 to 30 minutes, you ask them to recall those words. If they are not good enough in this, you offer them a new list of 50 words, including those 15 from the beginning, in order to recognize the correct words. And in Alzheimer's disease, another type of cortical dementia, you will find a low score on all 3 levels. But the problem is mainly in encoding and storage due to lesions in mesiotemporal lobe structures. Consequently, you will have a delayed free recall, diminished also, and recognition not so good. But what is going on in subcortical dementia, especially in PSP? They're not good in encoding and storage, but for the completely different reasons. The reasons are attention deficits, lack of strategies of learning, then working memory deficits, and delayed free recall is also showing low scores. But after giving them a new list and queuing, actually this recall dramatically improved. And these discrepancies between delayed free recall and recognition is actually a hallmark of memory disturbances in subcortical dementia. This queuing is probably an equivalent of nagging in a daily routine between husband and wife. If the patient does not remember what he ate last night, but the wife is reminding him, have you ate pie or nothing? And he said a pie, he probably has a subcortical dementia. And as I said, this could be found in any Parkinsonian disorder at some level, but such dramatic improvement on recognition in contrast to free recall is mainly characteristic of PSP. Executive dysfunction is actually a hallmark of cognitive impairment in all basal ganglia disorder, reflecting dysfunction in frontal subcortical circles. What does it mean, executive function? That is something similar to qualities that good executive directors need to have in order to run a company. They need to be good in planning, good organization skill, multitasking, problem solving, attentive with good self and emotional regulation, and that are ready to accept novelty. How we can test that in our daily practice? It seems that phonemic fluency test is more sensitive, the most sensitive on such disorders. And it seems that it is easier to answer as many words as possible, starting with the letter S. But you need to have a preserved attention, then a strategy to access your previous knowledge and semantic memory as well. Then, when you speak out one word, you need to put the word in a working memory, actually, and then in order not to repeat that word and to avoid perseveration. And look what happened if this is not actually working. This is an extreme example.
Good.
Mm-hmm.
Serbian. 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 Serbian.
She can't stop repeating the same words, starting with S. A lot of perseverations. Then the problem of suppression of irrelevant responses. Another simple test that you can perform is Luria 3-step test, motor test, which is actually equivalent to verbal fluency test, and presents an inability to perform a planned motor task or change the pattern of a motor task once it has already started. And this task as well you can find in all Parkinsonian disorder, but more prominent in tauopathies. Another simple test, again, is applause sign, and it was initially presented as test specific for PSP. And there was a debate, what is actually positive applause sign? Is that stereotype behavior or apraxia? But more it seems that it is motor perseveration phenomenon as well, due to loss of inhibitory control in initiated planned motor patterns. And the low performance on these tests you can find in all Parkinsonian disorders, but the most profound executive dysfunction is mainly reserved for PSP patients. What about apraxia? Different forms of apraxia are named hidden gems of the brain, which are giving us insight in complex interplay between different motor and cognitive networks. Why they are hidden gems? Because if you do not search for them, you will not find them. Sometimes they are not so obvious. And what are the patient complaining about? Mainly that something strange is going on, at least at the beginning, with their hand, that they cannot explain what's going on, that sometimes they have a damaged only a fine movements that you can sometimes mixed with ataxia, but in the absence of ataxia, pyramidal and other signs, think about limb kinetic ataxia, which is more specific for CBS. Pay attention to her right hand. It is a little bit clumsy. But idiomotor apraxia is more obvious. Again, if you ask a patient to repeat these gestures or imitate movements. And sometimes these signs are more obvious, such as spontaneous arm levitation, probably due to loss of proprioception arising from parietal lobe. Patient is not even aware that arm is assuming this abnormal posture, but still he is able to put it down on command. You will see on this video. In contrast to alien limb phenomenon, where patients feel that arm actually doesn't belong to their body and does not follow any command.
Smetam i luk. A recite mi kako biste mahali nekome za srećan put tom desnom rukom? Ja ne bih mahala. Dobro.
The right hand is almost useless now. Sorry. Something is blocked here. All these frontal and parietal signs are rather a continuum of disconnected brain networks than isolated signs, and sometimes it is very hard to define them, but we should pay attention more on such disturbances because, as you saw, they are a clue for final diagnosis, especially in corticobasal syndromes. There is another form of apraxia, apraxia of eyelid opening. You heard from previous lectures that there is a debate, is this dystonia phenomenon or this is real apraxia? Some authors implicate that this is maybe a local freezing phenomenon, but this phenomenon of eyelid apraxia is actually now included in criteria for PSP together with square wave jerks. You saw this video on previous slides, but again, you need to pay attention to that or ask the patient to close their eyes in order to notice this phenomenon. There is also apraxia of speech, and today there is more insistence on the observation of motor speech and language disorder in atypical Parkinsonism, which are actually markers of underlying tauopathies. You will not find this kind of speech disturbances in synucleinopathies. Apraxia of speech, this is the first lady. I need a tone up, if it is possible. Thank you. So there is a slow speech rate, equalization of stress across syllables and words, distortion of words, but without language deficit still. And it rarely occurs in PSP, but once it appears, it has a really high specificity for this disorder.
Možete mi koji danas datum, mesec i godina?
Datum 25. april.
Koje godine?
12. godine.
Dobro, jel znate kako se zove ova ustanova?
Znam.
Kako?
Za neurologiju.
Dobro.
This is actually non-fluent aphasia. You heard the telegraphic speech. There is also impaired prosody as well. But these two disorders, regardless of etiology, usually co-occur in syndromic fashion, and combination of apraxia and speech and non-fluent aphasia is more characteristics of corticobasal syndrome than of PSP. When you want to test visuospatial perception, clock drawing test has been traditionally linked to this cognitive domain, but it is not reflecting only the damage of posterior cortex. In order to draw the clock, you need, again, some additional cognitive domains preserved, such as constructional praxis, conceptual thinking, attention, strategy, executive function preserved. So you can find a clock drawing test in a different Parkinsonian disorder, but in PSP, this is the result of executive dysfunction together with gaze palsy. In corticobasal syndrome, this could be a result of hemi-neglect as well. Early affection of this clock drawing test could point out to dementia with Lewy bodies, but still you need to be cautious with this test if you just think that it is showing visual perception abnormalities. Anyhow, you should bear in mind that tau pathology has a greater tendency to be located in certain cortical regions compared to synuclein, that parietal signs are more specific to corticobasal syndrome but could be found in overlap phenotypes of PSP as well, and that we need to search carefully for these signs. Behavioral abnormalities are frequent. They are not secondary to the severity of motor impairment. They appear to be independent and integrative part of underlying neurodegeneration. And if you look specifically in the aspect of mood, disinhibition, and presence of psychotic symptoms, this can be useful again for the distinction of these three patterns. What about mood? Apathy is defined as a loss of interest. Their caregivers are complaining about lack of feeling, interest in any particular concern about specific situation or life in general, and this mainly belongs to PSP. You will not get the same impression in MSA patients. They are rarely plain in their emotion and interests, and they are rather depressed, sad, and I would say that they have an insight into their illness. In PDD and DLB, you will find all three types of mood disturbances, but again, a more profound apathy is a characteristic of PSP. But the signs of disinhibition are more crucial for differential diagnosis of such disorders, and we recorded some examples in our outpatient clinic.
Izađe,
Kakva je to pesma sad?
bio sam ja takav i ti bi čutala.
Nisam nikad čula tu pesmu. Koja je to pesma?
Ja kažem tebi čut.
Šta ste htjeli, Vesna, da uzmete?
Ovu čokoladu.
Koliko hoćete da pojedete?
Sve hoću.
Sve da pojedete?
Da.
10 dana. Sve isto. Jela bih boraniju svaki dan.
In one word, this is amputation of social skills, inappropriate behavior, impulsivity and loss of self-control, binge eating are mainly reserved, again, for the patient with PSP across Parkinsonian disorder. Sorry. On the other hand, hallucinations and delusions almost exclusively belongs to Lewy body disorders. They are not exclusion criteria, as we discussed previously, for tauopathies and MSA, but their absence support their diagnosis. And usually, these hallucinations are well-formed, detailed, with daily fluctuations, with sensitivity to neuroleptics, but this pattern of hallucination are mainly reserved for DLB, but it could be found also in PDD. And once you closely define cognitive and behavioral deficit in all Parkinsonian disorder, these patterns will get a full diagnostic value only when you put them in a time frame of Parkinsonism and other neurological signs. And this can be best illustrated by the example of DLB and PDD, where this time frame of onset of dementia and Parkinsonism is actually a clue, main leading clue for the diagnosis. This is a patient with bilateral symmetric Parkinsonism, anteflexion, skiing position, small steps, and postural instability. But he is also reporting visual hallucinations.
Tako sam i prozvao.
Kako ste ih prozvali?
Nevidljivi.
Nevidljivi,
Da, i sada tu, na primjer, Epi Kučića ima. Dosta često se javlja, tu sam primetio, ovce. Jedan mi je stalno u kadru, to je lep konj jedan, sa jakim, nenormalno veći od naših konja. Po toga najčešće i najviše vidim kroz prozor moj jedan iz dnevnog boravka, to je...
I šta tamo vidite?
Sve, kao televizor. Ne znam kako to da vam objasnim. Kao kad se seče slika. I odjedan puta nestane, pa onda se javi.
It suddenly disappears, then appears again. This probably refer to fluctuation on a daily basis, together with a well-formed, detailed hallucination. And screening of cognitive testing revealed diminished scores in clock drawing test, as well as in copying a pentagon, together with executive domain, declining in the executive domain. And if you just look into this pattern, it can fit also not just to DLB, but also to dementia, Parkinson's disease dementia. And just based on this pattern, you cannot distinguish these two types of dementia. But if you put this scenario after an average 10 to 12 years in the established Parkinson's disease, it is probably diagnosis of dementia in Parkinson's disease. But if this scenario you put in the first 1 year of Parkinsonism onset, then diagnosis of dementia with Lewy body is more likely. According to DLB diagnostic criteria, dementia is essential for diagnosis. Prominent memory impairment is not obligatory, but our patient had a deficit in attention, executive function, and visuospatial domains. Then he also fulfilled these core clinical features of fluctuation of visual hallucination together with RBT. Then someone gave him neuroleptis, and he had a worsening of both hallucination and Parkinsonism. There is another supporting indicative, so-called indicative biomarker. That SPECT revealed reduced accumulation in basal ganglia. On FDG PET, there is low accumulation of nucleus in the posterior part of the cortex. So he fulfilled diagnosis of probable DLB, especially that Parkinsonism and dementia occurred within 1 year of the beginning of all symptoms. So far, a clear and objective distinction on Parkinson's disease are actually, sorry, just a second. So far, a clear and objective distinction between Parkinson's disease, dementia, and DLB, other than this arbitrary timeline and cutoff, does not exist. And you can look at Parkinson's disease as restricted Lewy body pathology in basal ganglia. Look then on PDD as already widespread Lewy body pathology in the cortex. on DLB, there is even more widespread Lewy body pathology, but together with Alzheimer type pathology. And this idea is not new. More than 20 years ago, Trojanovsky group introduced the clinical spectrum of Lewy body disorders, and it stands the test of time. You are thinking about PD as extrapyramidal disorder with more or less pure Lewy body pathology. Then you have a PDD after established Parkinson disease, then DLB squeezed somewhere in the middle with Parkinsonism, dementia, cognitive features, also of Alzheimer's disease. Then you can have slight Parkinsonian signs in Alzheimer's disease and pure Alzheimer's disease at the opposite end. And there is not just an overlap of clinical features, pathology, and neuroimaging findings between Alzheimer's and Lewy body disorders, but also genetic overlap is present. Studies in DLB show that identical genetic defects are associated with several phenotypes in this line, and this suggests that these diseases share some underlying mechanism, but probably some other genetic or non-genetic factors also play a role in their phenotype. And we are pretty much aware now that some of the variants of GBA has a really high odds ratio for dementia with Lewy bodies. The heterogeneity of Parkinson's disease itself adds additional confusion in this timeline. There are patients with so-called malignant phenotype of Parkinson's disease, regardless of genetic forms. And it seems that the presence of these three non-motor features, early cognitive decline, RBD, and hypotension, all three together predict fast disease progression and the earlier occurrence of dementia. That is similar profile to that we seen in dementia with Lewy bodies. But they are skipping this one-year rule, and rather than trying to fit them into these artificial two ends of the same stick, it is more acceptable to see them as a part of the spectrum of Lewy body disorders. In previous UK brain bank criteria, dementia was early severe dementia was an exclusion criteria for PD. Now it is not anymore in MDS criteria, but the frontal-like pattern is an exclusion criteria in order to get away from the tauopathies. And this is a moment where particularly important is to define these patterns in such patients. And the differential diagnosing among frontal temporal lobe diseases is even more complex and presents real diagnostic challenges, especially due to overlap between these 3 repeat and 4 repeat tauopathies. And this is our patient at the beginning of the disease. This is how she came to our outpatient memory clinic. This is her outfit.
Pravo, dušo, pravo idemo. Idemo pravo. Pravo, skroz dole do kraja hodnika.
Molim, kaži, Darko.
We thought that we are filming her for TV. And at that time, she had the signs of early behavioral disinhibition, excessive consumption of cigarettes, and cognitive profile that fits to the diagnostic criteria for behavioral variant of FTD. But this is the same patient after 4 years. In the next 4 years, she actually developed all PSP features with vertical gaze palsy, postural instability. And this scenario of behavioral abnormalities preceding motor features in PSP you can find in almost 60% of patients, and after only 1.5 years, 16% of PSP convert actually to dementia. Parkinsonism could exist also in frontotemporal dementia, but it is never a predominant feature, although genetic forms of FTD have more Parkinsonian feature. And it is precisely that the presence of early frontal dysfunction in PSP is actually poor prognostic sign together with early gaze palsy for rapid progression, this red line in a cohort that we examined. It is also particularly important to follow these patients at regular basis because in some cases the speed of progression is sometimes measured in days and months, especially those with the PSP-CBS phenotype of the disease. And even in the absence of MRI and EEG supportive finding, whenever you have a rapid progression of PSP-CBS phenotype, think about Jakob-Creutzfeldt disease. And in the last 30 minutes, I was trying to convince you that if you ask the patient to count as many words as possible in 1 minute, to perform luria, to applaud, imitate some gestures, to draw a clock, if you listen carefully to their speech and ask about their behavioral changes, you can get closer to an accurate clinical diagnosis of atypical Parkinsonism. And thank you for your attention.